Right, and in the market this morning, we turn our focus on what is happening in the public health, healthcare management. So we have our specialists here to take us through that. And of course, also we try to reach out to, Nairobi County, the Ministry of Health, to also be in this panel to tell us what is happening currently with the outbreak of cholera as well. Allow me to introduce our panelists this morning. We have with us Professor Walter Jaoko, who is the professor from the Department of Medical Microbiology, University of Nairobi. Also, we have Dr. Teresa Kinyari. She's the Vice Chair of Public Health Society of Kenya. We do have with us also Dr. Elizabeth Wala, Infectious Disease Specialist, and Dr. Jacqueline Kitulu. She is the National Chair of Kenya Medical Association. Thank you for joining us this morning. Right, you've seen that story, of course, the outbreak that began in Western Hotel. Now there is a debate on whether why should they close Jacaranda at Valencia and leave Western Hotel. We have 4 people so far there. They've died out of the cholera outbreak so far. We're turning our focus on public health management in this country, and of course looking at the magnitude and the scale of what is happening right now. Given maybe if we have another disease like Ebola, how will that be managed, right? Let's just begin with you, Jacqueline, right? Looking at the status right now, what will be your reaction?
Our reaction as the Kenya Medical Association really is that cholera is a marker of a broken down healthcare system. And this is a sort of disease that we do not see in countries where health systems are properly functioning. Now, when we're talking about health systems, we have to put this in the context of our constitution and who is responsible for what actions. So the county governments under the devolved system of healthcare are responsible for primary healthcare. And in this case, we seem to have a breakdown in that area. Looking at that constitution, and I'm glad you have a copy of it here, in Article 43, the Bill of Rights.
Yes.
It says every person has the right to the highest attainable standard of health, which includes the right to healthcare services, including reproductive health, and that's A. B, access to adequate housing and to reasonable standards of sanitation. C, to be free from hunger, to have adequate food of acceptable quality, and D, to clean and safe water in adequate quantities. And I refer to those particular items because the public health, Dr. Kinyari here, I'm sure will be talking about public health measures. They are all contained in this Bill of Rights. That adequacy, the safe water, the food, the housing, the standards of health. So in our situation right here, there is a breakdown in these areas. And I think our focus, therefore, then should not be to sit here and say pointing fingers. And I think that's not our role here,
yes,
to sit and point fingers. It is to come together and have a functional system. That if our county governments, that their primary role is that primary healthcare, public healthcare, then let us sit down together and work together as teams to make the system function. Because cholera basically is just implying that systems have broken down. It is a disease that if we had adequate water, if we had adequate sanitation measures, and if we had food handled as it should be in a functioning system, we would not see any cholera. It's, I mean, when you look at how you even manage cholera, it is the simplest of diseases to manage in terms of even what the medications you'd use. If you had to use any, it would be the cheapest. So it's going back to systems. It is systems. What is happening within our systems? That breakdown is what we need to deal with.
And the government has been a bit cagey with information on how many people are actually, or the scale and magnitude of how this has adversely affected the population, especially here in Nairobi. The politicization of this, where is it taking us? Because we see from the Ministry of Health within Nairobi County, they're starkly denying that, first of all, it was cholera outbreak. And you can see there was 2 opinions which were diametrically different. Teresa?
As a Public Health Society of Kenya, based on what you've said, We're actually very disappointed by the lack of transparency by the national county government and the ministry.
Yes.
Because we know that cholera is a reportable disease, and it can easily spread within a very short time. And by not reporting the cases, then it means you're not able to quarantine the people who have a confirmation of infection. And again, the main thing is that we don't want to look bad. And I think this is a high time that people stop being, we all stop thinking that we don't want to look bad and really take the bull by the horns and basically just say that we've not done it well as a government, and basically we need help. Because as the Public Health Society of Kenya, we feel that as technical specialists in this area, we have a broken down system, as Jackie has said, and we have the expertise, but somehow we don't have any kind of collaboration and intersectoral collaboration. For example, with the National Construction Authority, we know that they are primarily responsible for most of the construction, which is now related to the sewage and the water systems. And we should have had some kind of preparedness, because earlier in the year, because of drought, we had water rationing. And every time we know that there's a water rationing and drought, there's always the possibility of getting an outbreak. So in the sense that the question then means, again, without pointing fingers, who should have been responsible for this preparedness? As a Public Health Society of Kenya, we don't run the health services, but we are available to provide technical expertise and advice. And most of these technical changes are really about refocusing and prioritizing on water and sanitation and hygiene, and really making sure that, since we know the hotspots for water and sanitation problems, then we really should be able to put in the measures. And like we've just seen, it's not just in the slums. We have a lot of unhygienic practices even in the big hotels. For example, you're given a warm cloth to wipe your hands before a meal, and that obviously would be a no-no in the public health, given the current scenario. You'd rather use wipes and all that. So there's really a lot that needs to be done. And as a Public Health Society, we're actually available. So we feel that we should educate. So a warm
cloth is a no-no? I thought they're sanitized. You can smell Dettol or whatever.
But at the end of the day, they are recycled. And using a wipe then means that you dispose of it, and basically then there's no risk of transmission. The other thing is that we also have food handlers within the hotels, and they are supposed to get frequent checkups, and mainly to be able to confirm whether they have any kind of infection, including typhoid and all the other diseases. But for sure, then it shows that we basically have not been able to achieve that. And it's really a shame, because like Jackie says, this is a really easy disease to deal with. And basically, hotels should actually have taken measures, for example, to avoid cold salads and basically food that would be at risk, and just ensure that they screen their health workers well.
So were we really slow off the mark, truly, when we knew that this outbreak was in Karen during a wedding, right? You talk of preparedness, right? Now we have the scale of it happening in Weston, Jacaranda, and San Valencia. Did the government actually, step in swiftly to make sure that they had the immediate intervention to try and stem the situation? Or we just remained, laid back, and we thought this will just step her off? This is just maybe a one case in a million that has not happened in many years. Professor?
I think we were slow to respond. That's an obvious fact. On diseases like cholera, what you require is public knowledge and information. This is not a disease that you deal with very secretively.
Yes.
Unfortunately, I think sometimes image overrides all public concerns. And so when you have a ministry official telling you, okay, we don't know this is cholera, we are testing it, but up to now you have not had the results of those tests. So when you have an outbreak of cholera, the first test that you normally use is what you call an antigen test, which detects immediately, but you can still not rely on that test. You require something what we call culture. So culture is like the gold standard way of diagnosing a disease. But that will be out in about 36 hours. You should be able to know that it is cholera. And immediately, you should have public health information, messages on media, in public places. So it's not something that you deal with hiding. And then the next outbreak, you know, again occurs because people are not aware. In the first place, you've denied that it is not. You've had now information that it is, but you're still not communicating to the public about it. I think, in my view, is that we as a country have concentrated so much on curative services more than public health services. And public health services are much cheaper. They deal with the larger populations. Curative, it deals with individuals. So you hear us talking a lot about the cancer diagnostic treatment that we've put in every county, the CT scans and all that. And these are very expensive equipment.
Yes.
And it's a shame on us as a country that you're dealing with these curative, expensive modes of treatment, whereas public health, which is just provision of clean water, messages of washing your hands before eating. The picture you showed us about Mukuru kwa Jenga, that is public knowledge. We have always known it. What has been done about it? Do these pictures only make sense when there's a cholera outbreak? When people tell you they don't even have toilets where they can relieve themselves, people relieve themselves in rivers and water sources. It's public knowledge. Our efforts should be dealing with this kind of thing, provision of safe water,
yes,
you know, and sanitation.
Right. Let's hear from Elizabeth as well. Good morning.
Good morning. Yeah, I think I'll just reiterate what they've said, but what we are worried about as health practitioners is that we are currently in a nurses' strike that's going on in its 3rd month,
yes,
unresolved yet. So you are seeing our facilities, the government facilities are basically shut down apart from the referral hospitals. So in a situation where there is a threat of an epidemic or there's an epidemic going on, it is important that this is not treated lightly because the impact, right now we have 4 mortalities unfortunately, but the impact of this outbreak could go over and beyond anything we can imagine. So I think it's something that should not be treated lightly because we have so many things failing in the system from all the 6 pillars of the health system. Now at this time it is the health workers who have, you know, so many issues. And then we also have the 2 governments, no one really knowing who's taking command. In the constitution, management of epidemics or public health issues lies with the county governments. But when you see the reaction that came from basically the Western Hotel incident, is that the national government is the one that came up and the county government was totally silent. So when it comes to such things, it's important that the county governments are well equipped to handle emergencies, to handle threats of epidemics, and then the national government is coming in to support. But we also have deficiencies in surveillance. Because of the devolution of health that happened, it's not just with cholera, but with very many programs, we are seeing a breakdown of information trickling from the counties back to the government so that there's a collective action that should be taken. So it's important that these systems are strengthened, that different units are given capacity to take over the mandates that they are supposed to do.
Right. Can we also talk about, you talk of epidemics, especially within the counties, and we know the buzzword right now is within also the World Health Organization, is the integrated vector management system. How are we, looking at the continuum of the health system in Kenya? We talk of breakdowns right now, but it seems, yes, there is no correlation between departments or amongst the departments that we have within the government system. Information is very key, as you say. This is a reportable disease that, we should be given a blow-by-blow account of what is really happening. But currently, as we know from the government, the numbers that we are being given and the numbers on the ground, they're not really telling. What is the accurate number or the accurate picture of what is happening on the ground? Because I'm given to understand, like Kenyatta National Hospital, the wards now are full. We cannot even talk about the private hospitals as well. What is the clear number? I don't know, maybe all of you might be cagey because you're not you're not holding brief for the government and you don't want maybe to but can you give us a scale of the magnitude of what is happening on the ground right now? Let's begin with Jacqueline.
I don't think I can authoritatively give you an accurate number of what the magnitude is.
But we can say it's good, it's bad, it's worse, right? So amongst the three, what choice of word would you use?
Let's talk. If we look at how, let's just take a step back and look at how cholera spreads. Now, cholera, it is a bacterial infection. It's a diarrheal disease, and in most cases, most people will have mild to moderate symptoms, and maybe just about 10 to 20% will have severe disease with, profuse diarrhea and vomiting and cramps, and some will even go into kidney failure. Now, those are the cases I think we are talking about when you're asking in terms of magnitude. Who are those with severe disease? However, even those without severe disease who have the disease can spread the disease. Therein lies the danger. So that even if you have even just 5 people and undetected, and they are working in an environment where they are touching food and will contaminate it, again going back to inadequate water, let's put it in context. We've had water shortages, so there is no water, or what we've seen, I think what the clip you just showed, someone who, there are no toilets, so their hands are contaminated, touch food, and they work in a food industry. Look at how many people then are instantly exposed. So while we are worrying about the severe cases who are in hospital, there's many others out there. Now you just need that person. The way we live nowadays, I think when you read the older books, they'll say cholera will happen in underprivileged areas. No. Those people work where? They work in the hotels, which may be 5-star. So those people, then in that sense, you can have that disease transported to this 5-star hotel. Then you have a case of a conference happening and several people are hit by the disease. Then you have those who are there, so some of them who are mild illness and moderate illness, a bit of diarrheal disease, again, don't even think they are a risk, and they go to a bathroom, there's no water, touch, and then you have them move from the, so I want to use the conference example because people came from all over the country. So then they leave Nairobi with it and move back to their country, to their counties, move it there. Some of them will then the next day travel out of the country, transport it out of the country. Are you seeing the magnitude? Yes. So it's not, when we're focusing on just the very ill patients, the disease can transform greatly. I think you started with that clip, you're saying that there's cholera now in 12 counties. It can actually be the whole country just in a click like that. Because as long as we are as mobile as we are all at risk in that sense. So it goes back to then what Professor Jaoko said. Then you must identify what it is, and you need to call a horse, or call a spade, and not a big spoon, because until you name it, you can't deal with it adequately. If you call it food poisoning, then how you manage it varies. If you call it cholera, the steps are ultra clear. And that's where then you come in the public health reporting, the disease surveillance, and I think we have all those units. That's, I think, one bit we have within our health system. All those units are there. It is them implementing what they should do and get out there. And it's, as you said, it's a collaborative effort. As health workers here, we have to be part of the process. And that's those are cogs which I think the health system should use. With us as the Kenya Medical Association, we can, mobilize our health workers, the public health society, getting messaging out there. And I think I want to note, like as the media, what you're doing, highlighting it in the newspaper. Maybe you're doing it in a scare tactic, but I think there's also, well, yes, when I think the headline you read in the Kiswahili paper is quite, that is scary. But I think
maybe that's how it sounds in Swahili. I don't know how it will sound maybe in Kamba, or it will be even worse.
But I looked at, I think what was in not yesterday's paper, the day before, very informative, and that's what happens, because you've identified it is cholera. Public health messaging, then use media, use radio, use social mobilization, use the church, use schools, spread the message. And it's a very simple message. Wash your hands. For food, you're saying cook it, boil it, peel it, otherwise leave it, If it's a salad, leave it, because it's not cooked, it's not boiled, you can't peel it. leave it alone. You know, it's simple messaging like that, which needs to be mobilized. But you can't do those things until you name what it is you're dealing with.
Well, maybe we were actually placing a very low attention or a low premium on this particular disease. Yeah, it's not really in the magnitude of what we know as cancer or HIV/AIDS. So cholera, who really bothers about cholera? But you say, you know, this can be a very, very, you know, detrimental disease that can actually kill people within very, very few hours as well. So you think the government has been playing politics with this? Because, yeah, you say, and I bet all of you are health workers. You easily tell a food poisoning symptoms and, you know, also cholera symptom. So how comes we were told that this is a food poisoning? Then again, it changes now to cholera. Or now we have to wait for the culture results so that we can verify, which is good, of course, to have empirical evidence. But I bet as health workers, off the bat, you can tell, hey, this is food poisoning and this is a symptom of cholera. Teresa?
I think, like Jackie says, the signs and symptoms are basically quite clear. The only thing is that we have a continuum. Majority of people basically get exposure and a mild illness, and the ones we have in hospital are really at the tip of the iceberg, which means we have many more people who have the symptoms, but or may not have the obvious symptoms, but are actually spreading it.
Yes.
And like Jackie said, you know, cholera is a bacterial infection. And we normally say it's comma shaped, so it's basically hooks onto the gut, and within the very first few days, you get very painless diarrhea, which is what we call the rice water stool, and with that painless diarrhea, basically, then we don't expect to do anything about it, but we are actually highly infectious. So. And also we have this problem of being able to quarantine people. We are mobile city, and we have people working in big hotels, living in the slums, and of course that is really an issue. So we have a room for mass treatment, and I think this is one of the things, as we try to sterilize our water with Aquatab, we really need to consider mass treatment just within the administrative boundaries of Nairobi County, and also within the other counties.
All right.
Yeah.
Let me drop in Professor Jaoko. The politics in this. What are you reading so far? We have Jacaranda, we have also Weston, we have Valencia. We don't have a broad brush that, you know, wraps all of them. Yeah, it is very selective on this. What are you reading? Yeah? Well, let it all hang out. Don't be very cagey with information.
That's very, very hard. I think I should just start from where Jackie says, probably not pointing fingers, but being very truthful. Of course, by the way that the issues have been handled, you would almost be inclined to think there's a political angle. And unfortunately, that should not have been. Although we are saying, for example, that confirmation of cholera is on culture, the symptoms are very suggestive. So the message I would have given as an official of health is to say we have an outbreak of something that appears to be cholera. We have collected samples. We're in the process of testing them. These are the messages, the preventive messages, very simple that as have been shared here,
yes,
about washing of hands and so on and so forth. So the messages should come out immediately. The messages should not even wait for the confirmation of the cholera. You say, this looks like cholera from the signs and symptoms. We have taken samples for diagnosis. We will confirm it, but in the meantime, do this, do this, do this, do this. And when the results come,
yes,
please come back to the population and say, the results have come, it is cholera. And now we have put, by that time, we've already put mechanisms to contain the disease. But the way we are, it's like a hide and seek.
Yes.
It's like you're being sorted, you're being looked after. People are following you to find out what's happening.
We're trying to call them, they can't come for the show like this. I mean, this is a good opportunity. Yes. We call you. After you don't show up due to unavoidable circumstances. Yeah. They tell us.
To me, that is the problem. Yeah. That is the problem. Now, the measures that have been instituted make sense as long as you don't do it selectively. That is number one. And we should have done it even much earlier. When a cabinet minister tells you that now we're identifying the people who vend water, we are screening them, we are finding out what the sources of water is, come on. These have been going on.
Yes.
Do you have to wait for an outbreak of a disease for you to do those very simple things? The other thing is, you know, water sources of contamination are very multiple. You can test your water at the dam, okay? You chlorinate it, you test it, and it tells you this is good for human consumption. The problem is that this water, some people have even said the water passes through pipes. They go through some places where sewage has burst somewhere. There's an open water that is also spilling water. The sewage comes into the water. So you have to repeatedly be testing water at the point of use. So you have places where you just randomly, we call it surveillance, you just collect water and test it. And when you're talking about water-borne diseases, it's not just cholera. We might be having typhoid. We might be having other water-borne diseases. So the idea is not even just to focus on cholera, it's to focus on safe water. Safe water. And other health measures that can be able to prevent other diseases as well. Some years back, we had the ministry, remember the time we had the ministry split into medical services and public health? Yes. What happened to that time? That time was a recognition that public health is important. What happened to that arm of the public health when we merged the ministry? How come it's not visible? We are very, very visible on the medical services, but the public health has died. To me, that is a challenge for the government. All right, we'll come back to that. But let's hear from Elizabeth, when especially it comes to food handling, because I know also this is your area. We can have the food handlers. Now we hear that, they need to be certified. We're having these band-aid solutions that we have also the water sources, people who, you know, are dealing with the water hawking right now also should be certified as well. But you as an infectious disease specialist, how are you managing this area of certifying this food handlers? Is it within your remit?
It's not within my remit. Actually, it's more of the public health area. But I would want to emphasize on two things. One is our capacity to actually screen all those people, because we have very few public health specialists who are mandated to carry out those screens. The second one is on the corruption. The corruption within our system generally as Kenyans. People are able to get these certificates without necessarily going through those tests. So it is a good measure to undertake, but is it realistic? Is it something that will be done continuously, sustainable? Because it's not a practice we've been doing, especially for the open air people. Anyway, I can make mandazis in my home and go to the streets and sell. And you know, we have all these inspectors passing by and no one is really taking care. So what I see more now is a knee-jerk response rather than something that is sustainable, something that is longer lasting. We need to change as a country in terms of our behaviors, in terms of our hygiene practices. We need to change in terms of our perception of what is good for us, and not just me minding my own business, but also looking at, if I don't do this as a person, or if I cut corners, or if I take bribes, I don't issue these licenses, what's the impact of the person next to me? Or maybe next time it will be my family being impacted by someone else. So I think it's a very big systemic failure that needs to be approached more in a sustainable manner rather than just because something has happened, because maybe our top government officials are the ones who have been affected this time round. Now let's do this and that and that. The other thing that I'd want to emphasize is in cooperation or coordination with private facilities. As I had mentioned earlier, public facilities are right now run down because of the nurses' strike. But on the other hand, we have private facilities that are able to offer or to support or complement what the government is doing, and especially in laboratory testing. I think when the second case at Western Hotel happened, we had quite a number of private facilities, laboratory facilities coming in and saying, look, we can also do these cultures on our own. But then we had a gag from the government and said, no, only the National Public Health Laboratory can do this. So how do we, in a situation where there is a pandemic or an epidemic, how do we loop in? How does the government say, look, I need help from the other players in the field so that we are all working towards one kind of response, rather than the government being, so closed up, Because I myself, if I got cholera, I would not go to Kenyatta National Hospital. I'd go to, say, because I have a medical cover, I'd go to a private facility. Now, if this private facility is not even aware of the measures they need to take when there's a cholera epidemic, then we are not supporting the whole response to it. Yeah.
Yes, please.
Look into that. There's a huge potential here for the public-private partnership, which is something that we've talked at nationally at different levels, but never get to effecting it. As the Kenya Medical Association, we are members of the Kenya Healthcare Federation, which is the health sector board of the Kenya Private Sector Alliance, KEPSA. Okay. And I think that's one area we have tried to push a lot for in terms of public-private partnership, that we have private facilities that have a lot of idle capacity. So when we are talking about the screening of food handlers, I mean, there are tons of food handlers in this Nairobi County alone, if you're going to talk about Nairobi County. Now, the medical examinations are done only in public facilities, which have less than adequate capacity, yes, even facilities to handle those testings. So that when you look at it, essentially, I was talking to one laboratory, senior laboratory technologist, he told me, no, those ones, they do what we call sink tests. I said, sink tests? What are sink tests? He says, oh, you get the specimen from the patient, from the food handler, and you pour it in the sink, and then you write a report. You don't even do anything to it. Which is a very sad thing to hear. But then we have, I mean, so there's systems, there's standards to be maintained within the public health sector, but there is also this private facilities with a lot of idle capacity. So you have a fully equipped lab that has a potential, which has the capacity to do 100 tests and does 20 tests. You have this public facility that has capacity to do 100 tests that has 500 to do. So why not, come into partnership where you're all working towards one common goal, ensuring that all the food handlers are adequately tested. So there is a lot of resistance, I think, in terms of working from the public sector, incorporating with private sector. I think there are fears which are unfounded. Well, maybe in some cases there may have been some issues that may have arisen, but there's a Public-Private Partnership Act, which I think those are things which we really need to put into place, take advantage of all the other facilities. I mean, when you look at it actually statistically, more than half of the healthcare services are provided in some sort of private facility. When we say private, many people think Nairobi Hospital, Aga Khan. No, private is everything, even that little one in the little clinic in the estate. That is a private facility. So we are looking then at let's broaden the base in terms of going back to really what you were saying, that intersectoral collaboration is not enough. We also need to bring in all other players, the public sector, the private sector. And then when you're sharing the guidelines, as Dr. Wala said, you then need to share them across the board. So that you don't have one facility able to manage the crisis and another one that has no clue what they should do. That is the message that should be coming out. When you've named this animal what it is, and you call it cholera, you say these are the next steps. And that message goes out to all facilities. And there is a central coordinating unit again, which goes back again to that public health sector.
Right. So when we come back also, we will establish, okay, we have doctors on the front line of this, or at the tail end of this, but who is on the front line? Is it the government? Yeah, who is actually on the on that particular spectrum, on the continuum, until the end when we have the doctors really handling, so that we know, are we having a very robust also public health inspectorate that is working, right? We remember way back, we used to have these inspectors coming to our kiosks, right, every other week, and they're checking, going to the kitchen, then they'll certify you. So also, the option of cancelling all these food handlers' certificates, is it the way to go? Many thanks indeed for joining us. And of course, continuing to watch this particular conversation that we're having on public healthcare management in Kenya in light of what is happening with the cholera outbreak. And this morning I'm holding court with Professor Walter Jaoko from University of Nairobi, Department of Microbiology. Also, we do have with us Dr. Teresa Kinyari, the Vice Chair of Public Health Society of Kenya. Also, we do have Dr. Elizabeth Wala, Infectious Disease Specialist, and Dr. Jacqueline Kitulu, she's the National Chair of Kenya Medical Association. Right, before we took a short break, we are looking at who is on the front line and who is at the tail end. The doctors are the tail end. But coming now to the doctor, before we reach to the doctor, I should say, who are, you know, the other faces that we have on this continuum?
Okay, with the new health policy, we moved away from the levels. We had level 1, level 2 going up to level 5, and now we really have tiers. So really at the bottom we have the public health technician, who should do the inspection, not just meat, but really inspection of water and sanitation. And we basically still see a lot of garbage and poor sanitation. Mm-hmm. So again, at that point, we have a challenge, which then trickles on to the higher level, where most of the people end up with undiagnosed diarrhea and undiagnosed disease. And mainly because of what Professor has alluded to, we don't have enough methods and enough equipment and even tests available in the public health hospitals. And then that trickles down to the doctor, who now will get more firefighting after the patient has really incubated. So
we don't have capacity. But I heard Jacqueline saying that we do have, you know, enough capacity. Idle capacity, she talks about, yes, idle capacity. Yes, yeah. So is it the issue of capacity or the issue maybe of implementing what we do have?
I think it's both. Because first of all, you need to have enough health workers, and like what Liz said, we already have a nurses' strike, which already has paralyzed most of our healthcare system. So where do patients go, for example, when they have diarrhea? So there's an opportunity for public-private partnership, because we have the facilities in the private sector. And right now, the National Health Insurance Fund is actually supporting most of the outpatient services. So I think it's a question of individuals trying to seek health services, for example, by enrolling in the National Health Insurance Fund, and that will actually allow them access to the private sector. But on the other hand, we still have that individual efficacy, really about hand washing, because we basically are, we have access to water, but we need to really follow the steps of hand washing, ensuring that all the parts of your fingers, including the back and the thumb, are actually cleaned. We don't really have much time for that as individuals, because after all, in urban areas, we have running water. We can always get water when we need it. So I think that those are some of the things that we really need to look at. And again, we also have to look at the rural setting. I think most of the places where we have a problem accessing water still have that good water and sanitation practices, just because water is scarce, and they really have to know how to deal with it. And also because of not having latrines. There are places, for example, where a chief will not allow a young man to get married unless he's built a latrine for his new family. And I think those are the kind of things we need to really go back to. Just go back to basics, how we used to do it before. But then when you come to the urban areas, yes, we have a lot of high-rise buildings coming up, really choking the water and sewerage service. And right now we also have a strike with the for example, the Nairobi Water and Sewage Company. And we also have a lot of sewage companies elsewhere. But we need to ask ourselves, in what ways can the National Construction Authority and other sectors like the Ministry of Water be able to work with the Ministry of Health, and also with technocrats like us in the Public Health Society of Kenya, the Kenya Medical Association, in an open way, without passing the buck, to really ensure that each person plays a role. The problem now with our health sector is that we've really had vertical systems, because we didn't embrace the primary health care very early after the Almata declaration, but we still have room for that collaboration, because, for example, as a Public Health Society of Kenya, we have reached a critical mass of epidemiologists and public health specialists. Some of our members are in health financing, others are in economics and communication. So we basically have a lot of diverse expertise that is available to work together. And that's why when the outbreak came out, we didn't come to the press and make a statement, because we didn't want to blame anyone. We've basically stepped up educating the public and ensuring that we get in more information, because that is what really matters.
But when you talk about integration, because we normally see when the doctors are striking, the nurses are away. Where the nurses are striking, the doctors well. And I wonder in the hospital how you guys, you work together. So when you talk about integration of this system, why can't we see the faces of KMA and faces of UOs as well coming to the fore and supporting the nurses? Because I wonder, how do you treat these people in the hospital without the nurses? Are you the one also who's taking the nursing duties as well? So how does it work? Do you just come with a stethoscope, you watch, or the defibrillators, and then where are the nurses? So how is it adversely affecting you as well?
I think it's a big issue, but like Professor said, we've really focused a lot on curative measures, and of course the doctor is really the team leader in the health facility. So in this case, with the nurses strike, then the doctor ends up being overstretched because they really have to manage the facilities, which really brings us to the issue of the numbers. We really don't have enough doctors working in the private sector, and there are very many issues that have to do with health system strengthening. You really need to have equipment and medicine and actually facilities to work with, and it becomes very disenchanting. For example, even now with the nurses strike, I mean, the most you can do is really make beds, because sometimes you find that, of course, making beds would really not be very good use for our value as doctors, but you find that most of the medication, most of the facilities that our patients have then are not available. For example, a patient presenting with chronic, with very severe cholera, they have severe dehydration. We basically would need a nurse to monitor that rehydration. We wouldn't expect a doctor to sit in there and just monitor the drip, keep changing the drip. And when you look at the intersectoral collaboration, it's more of strengthening the health systems to keep the people within the health facility. Right.
When you come to Professor Jaoko, then also doctors should have also nursing as a minor. When they come to the campuses, it should be mandatory, right? Just in case we have a strike, they step in with the necessary skills. But I wanted to ask you, from this point of, let's talk about potable water in Nairobi especially, because you mentioned about, we have this entire system, the sewage system, maybe they're in parallel also with clean water. And when there's a burst, they mix, and this is what it really goes into our taps as well. But we talk about Rai itself also being a water aquifer, aside from Turkana that has been discovered as a water aquifer that can actually, make sure this country is water potable for the next 70 years. But we know in Rai also we have the sewage itself. It seems also the water table in this country is affected adversely. Whose initiative is it, from the public health standpoint, to make sure that, yes, we have good potable water in Nairobi? We have a broken system right now. You mentioned the National Construction Authority, right? But what is the role of the City Council itself? Because where we have high-rises in this country, and we know they're supposed to maybe have masonettes or bungalows, the sewage system is still the same 54 years down the line. What crisis are we facing?
Yeah, the problems are they're not easy. They require a multi-sectoral approach and very innovative ways, and sometimes we'll step on toes. I think the problem sometimes we have is that when you're given a job, it's easier to maintain the status quo. You rarely get people who come, look at the problems and face them and try to get solutions. I think more often than not, when we get such a person, they stand out. I mean, like when Dr. Matiang'i does something in education, he stands out. Whereas actually every ministry has issues that need to be addressed. But it's easier to flow with the wind and just maintain the status quo. So the issues, for example, of constructions and high-rise buildings and sewage systems, they require a lot of people coming together. How do you widen this sewage system? How do you provide clean, safe water to... We should not even be talking in a city like this of having potable waters. We should be, we read in the Constitution that supply of water, it's in the Constitution.
It's a right.
It's right there in the Constitution. Why can't we have effective systems of supplying water to people. They don't have to deal with this. First of all, it is too expensive. These people who buy potable water actually spend much, much more than the people who are getting tapped water. And yet they're the people who are on the lowest level of the socioeconomic ladder. So we should not really be even talking about this potable water. We should be thinking as a country, as a city, as a county, Nairobi County, what can we do in collaboration with the central government to ensure that everybody gets clean water? The construction one is a difficult one. There are so many, Dr. Wala has talked about systems of corruption and all that. Places where you should not have high-rise buildings, suddenly you get approvals for those ones. Apartments are even built on water reserve areas. Yeah. You know, it's just too complex. And nobody seems to want to face these issues head-on. And the situation will continue to get worse. And in the years to come, it will be very difficult to correct it. We'll have to have a very bold person to demolish high-rise buildings that are worth so much money. Mm-hmm. Why don't you prevent them from being set up now so that we have systems that are easier to manage?
Mm-hmm. All right.
Yeah.
Let's say from Elizabeth, we'll come to you, Teresa. The cholera vaccine, right? That also, I think, is a big issue. And right now, we are going, I know this will be another band-aid solution. Now, the Ministry of Health will come to the fore that, yeah, Nairobi residents, we need to be vaccinated before we come to the nation building, make sure you have a jab. I know that will be, right? But of course, we've seen also the handling of these vaccines as well. Busia is a case in point where we had the malaria case, and we had our children also being paralyzed or having those symptoms because of, you know, a vaccine that had expired. Even us will be gun-shy now to go for these vaccines because given the history that we've had in this country, how can we ensure the efficacy of these particular vaccines, you know, they're very safe? Yeah.
Yeah, so yes, we've had unfortunate incidences over the past with regards to vaccination, which has, from the West, we have a lot of push towards anti-vaccination. But fortunately, the cholera vaccine is an oral vaccine. But so it's given by mouth.
Well, it's not a jab.
No, it's not a jab. Yeah. So.
Oh, really?
Yes.
But what will be the difference?
In terms of?
If it's a jab and what will be
no,
the difference?
No, in terms of safety, anything that's injected poses a higher risk in terms of even how you draw it, the injection itself, whether the needle is recycled. So basically, an injectable vaccine poses a higher risk in terms of safety than something that's given orally. Okay. But that said, the efficacy of the vaccine is relatively, it's around 60%, and then it covers you for just a few months. So it's recommended in an epidemic situation and to certain populations that are considered at risk or have a lower immunity, like children or people with other conditions that reduce their immunity. But generally, the management or the prevention measures for cholera is WASH, which is water, sanitation, hygiene. Water, sanitation, hygiene. The vaccine comes in to complement. Even the antibiotics come in to maybe reduce the severity. If you just observe the principles of safe water, hygiene practices, and sanitation practices, then you're by and large able to prevent and manage an epidemic of cholera. But I wanted to, because on the side I'm also a very strong advocate of public health. When you mentioned that doctors are at the tail end, I think that's where we go wrong as doctors, if that's the notion that we're perceiving, that we wait for the patient to come to us. We have a very big role to play as advocates of health matters in the country. And part of this is the fact about the education bit, because you'd want to be left to deal with the cases that really have to come to hospital. For cholera, you do not want, patients should not be coming to hospital for cholera. So as doctors, we need to take that forefront lead of coming out and saying, you know what, we are going to advise the government, we are going to advise our patients, we're going to take advantage of opportunities where we can talk. But the other thing that I think that has also maybe fallen short is the media attention to this situation. I'm so glad that Nation Media has given us 2 hours to talk about an opportunity like this. But before, like when we were talking a lot about Western Hotel outbreak, we had a media gag. I think only Nation Media Group was the only one who was really at the forefront of bringing it out matters. Right now, the media is focusing a lot on elections. These voters may not be there on August 8th.
Maybe cholera is not as sexy as...
yeah, but let's tell it to the politicians that you will not have voters on August 8th if we do not manage this. So we need to give the publicity that it contains. And I think as our training as doctors, we are not taught to come out, in public, to market ourselves or to really speak out, and that needs to change. But we can only do that in partnership with the media. And I think such opportunities, I would commend the media houses for giving specialists or public health specialists the time to really set records straight. So when the government is saying this, and I am the type of person who is not shy to say where something has gone wrong. Leadership and governance has failed us in this cholera situation. Right. It's time we said the officials from the ministry have failed us. We accept that, and we say what needs to be done.
Right, but maybe also as media, we burnt our fingers. When you had your doctor's strike, we really took a flat from you guys. You know, you were really hard on us on, we don't know the issues, our report is flawed, you know, where did this guy go to school? You know, those things that really come to the fore. But aside with that, the question is, again, when we talk about vaccines, we've had also reports that we have fake drugs in this country, you know, coming from China, from India, you know, it is in the market. Right, and we talk about the vaccines, and I gave you a case in point in Busia. So, as we're talking about efficacy, how do we then distinguish between, you know, the fake drugs that we have in the market, and you know, even that one itself is a big scare for the public health sector?
Yes. So when you look at the health systems, as we keep on emphasizing, the 6 pillars, one of them is commodities. And commodities here are the drugs or the reagents that are required in the lab and things like that. So vaccines fall under them. Now, under that, there's the regulatory authorities. And that's why I said, as a country, corruption, if we don't harness this monster called corruption, yes. But by and large, as a country, we've made very significant strides in regulating, especially vaccines are highly regulated. So, and it's very hard to get fake or counterfeits of vaccines because they don't give as much return on investments as, say, antibiotics, which are faster moving. So it is easier to, let me say, it is, we are more confident or more assured on the efficacy of or the integrity of these vaccines because they're not part of the group that you'd think about being counterfeited. But that said, once a vaccine comes in, you have to look at the whole cold chain system. If it's a cold chain vaccine, is that the integrity has to be maintained right from the manufacturing industry to the way it is shipped, to how it's cleared at customs, because sometimes they come and stay at that custom, and many times I've inspected one of the holding facilities. They're not conducive to vaccines because maybe the immigration people do not understand the value of these are medicaments that need to be maintained at a certain value. And then they go to the national distribution facilities, and then now they go right to the facilities, to the retailers, and then now to the patients. So you see, at each step, integrity has to be maintained for you to have a safe vaccine. And then the person administering the vaccine needs to be trained to know whom to give it to, whom not to give it to, and things like that. So that whole continuum has to be... So
should we have a mass vaccination in light of what is really happening right now to contain, especially in Nairobi, Jackie?
Now,
do you think it's advisable?
I think going back to where I think the bits that Dr. Wala has just mentioned, in terms of controlling or preventing cholera, the steps are still wash. Water, provide clean, safe water. You sanitation. You know, we're talking about the sewage, how we are disposing of waste, and we're talking about hygiene practices and food safety. Those are the key issues in prevention and control of cholera. Vaccines will never replace those. They'll always come top. However, the role for vaccine comes in already, as we've mentioned, that the efficacy is not 100% in the first place. So in itself, you're not giving something that will give you 100%. But there is a role for vaccines, not to replace the water, sanitation, and food safety issues, but you can use it in where there are outbreaks, at levels like, epidemic, pandemic. Then at that point, there would be a role for using of the vaccine. The vaccine is not cheap, by the way, either. So you have to weigh against
but it should the cost, the onus of government, and in light of what is happening, because this is a pure failure from the government to make sure that we have safety in this country. So when you're talking about cost, this should be the onus of the government to actually
absolutely, and that's why I started. Actually, when you asked me, the first thing I said, I took this whole discussion back to the Constitution in terms of a right. So that you a right to health at the highest attainable standard, to safe water, to good housing and sanitation, and at the point where the system breaks down, then who is responsible? It goes back to the Constitution and saying yes, the government must provide certain things, but I think we also said in the same breath, as even as I said that, I think our function here today is not to point fingers and say that everyone is to blame. And I think as we've talked, all of us, there are roles where each of us have not done what we should have done, and I think it should be that point of collaboration at all times. That, there are areas where there are weaknesses and there are areas where some groups have strengths, and to get all those together. When you're talking about the issue of cholera, I think we almost see it as hospital. You're taking back to vaccination. We're seeing it as patient, and yet the bigger issue is actually even outside all those. It's literally, if you step away from it, it is safe water. That is not directly health. And those are the issues we call social determinants of health. There is water, there is sanitation. If you don't sort out those, they'll end up in hospital. So that health in a great way has so many other links, that when you're dealing with this issue of cholera, we should have had a task force really, or at the center, which has the Ministry of Water involved, which has the housing involved, which has NEMA involved, which has you are asking even before you get to the doctor level, which has there's a pool of health workers. Let me say health workers. We call community health workers or volunteers, people who are not even paid anything. Faith-based organizations who would do a lot. Not faith-based organizations, because those are hospitals, institutions are all set up. But there are people who in the community. This is a messaging. If we're saying that the primary focus is providing safe water, sanitation measures and food safety, who will reach the public? It is the community health workers do a great role of that. Just literally from door to door, I can tell you, this is how you wash hands, this is what you should do. So you need to pull in so many people to work with this, and that's where we are coming in. Even our role as the Kenya Medical Association, we say pull our doctors, that wherever we are, we can be part of that advocacy in terms of passing that information to others. So it's we can draw in, we can go and speak out in schools, we can go and speak out in churches, collaborate with people in our community, because we belong to communities, we don't live on our own. So this control, it is not one item. It's not going to be that cholera vaccine will be the solution. No, far from it. It is a functional issue. It is the system issue that all these players have to come in. There's safe water, there is adequate sanitation, there's food adequately handled.
The preventative point, aside from the curative, because those we can look maybe later, but for now, what will be the immediate intervention? That is what now I'm asking. What will be the immediate intervention? Aside from now teaching the public, because now also that will be slow on the uptake with the populace. It depends with the resources. We need to come maybe to the media and give out alerts, or of course also from the Ministry of Health within Nairobi County, or Ministry of Health entirely, coming and educating the populace, with the very frequent as well alerts, and also maybe media briefings as well. But you mentioned, I like the social health determinants that you really talk about, and water is very key. And this question that people now are asking, which is safe water now can I drink? Which is a portable one? Do I buy from, you know, the supermarket with all these brands that we have? We've heard also from the Kenya Bureau of Standards that yes, some of these, you know, bottled water are not safe at all. Right? So where do we go? We had the executive director of Nairobi Water Sewerage here says, you know, our water is the safest, it's chlorinated, right? But it is treated, but where does it pass through? At the end of the day, when it comes to the taps, how clean is it? So which is safe water? I myself, I drink from the taps because I trust the taps and I think it's sweet, sir.
I think you should boil it. It's very simple. I mean, boiling water would kill the cholera germ and would kill the typhoid germ and all the other things. So I think in a situation where we are not very sure, not many people can afford anyway bottled water, even if it's the unsafe one, it's too expensive. But we can afford to boil water, drinking water. So you boil it, let it cool, and that is what you take. Now, there are also some things that can be, you know, like water guard.
Yes, yes.
Yeah, you can put water guard. In my rural area, that is what people use. It's been marketed like nobody's business. So if you go to my rural area, you can find water guard in the shops. And it's cheap. It's very, very affordable. So you can put, and they have instructions on how to use it. I would say in a situation like ours where the systems are really broken. You're not very, very sure. Somebody can say the water is safe, but you're not really, really sure. I would say boil water, and if you're able to use water treatment chemicals like water guard, that would be there for drinking water. So then it doesn't become expensive. When you tell people to boil water, they think, oh my goodness, so you're boiling so much water. You're just boiling the drinking water, because the other waters, you know, when you're cooking, the food is already boiling there. I suppose for drinking water, just boil it, keep it in a clean container, and let it cool. Right.
Let's say from Teresa, because Ali had asked you, now cancelling all the certificates of food handlers, is that the way to go, right? And then I want also to know, do you think the ongoing strikes that we've had with the doctors and the nurses, also they've exacerbated the situation? Because we don't know how many people maybe were not treated in the hospital. Yeah. Do you think, you talk about a collaborative effort, but how have you contributed as doctors yourselves?
Okay. Maybe the first one, really about the closing down, cancelling the food handler certificates. I think once you cancel the certificates, it means that you're not confident. You're not really sure that you actually gave them out correctly. So it means that you've already accepted the fact that they may have been, they may actually have been bought, or the corruption issue that Liz talked about. So I think it's a shame that we would react by cancelling food handlers certificates. The main thing would be to actually focus on prevention, because even if you cancel the food handler certificate, does that mean that they'll stop practicing?
Yeah, like you hear now, yes, Jacaranda says, no, that's not the case.
Yes,
like what you're reading right now, we're still operative, we've not closed. So will I go to Jacaranda knowing that it's been closed? We don't have a clear statement. Who do we trust?
Yeah, and again, there's a selective approach, because we basically should think about ensuring that, basically we should test again. And we still know about the incubation period. So if you test negative now for cholera, doesn't mean that you don't have, you could be incubating it. So I think it's really, we really need to be very realistic in terms of being able to deal with cholera. Now, as doctors, whether the strike contributed to this, I wouldn't really say that it didn't, or it did, because the reason why we had the strike was because we are working with almost nothing in the health, in the public health sector. Most of the doctors have actually left the public sector because they are disenchanted. You have a lot of training, and basically you cannot be able to deliver, and most people actually feel helpless. But in their absence, really, like you said, we basically are not responsible for the fact that patients are coming with cholera. We still takes us back to health education and behavior change. So yeah, so I don't think we can blame doctors for exacerbating this condition.
Right. Before we come to you, Jacqueline, we have another doctor hanging on the line. Dr. Kai from Edgerton University. Good morning, Dr.
Yeah, good morning, the panelists. Okay, thank you, Inea.
Yes.
I want to make a comment on this particular disease, actually, called cholera.
Please.
It's unfortunate this time and later that we, as a population, as we are growing, we also develop diseases like cholera. And I want to point out on one or two issues here.
Yes.
Is that our hygiene has been wanting. Since we developed system of health, even here in Nakuru, there's a serious problem as far as sewage management is concerned. You find a sewer line and a clean water line that are running line to line. So every time there is a leakage, there's a whole contamination. So what I'm appealing to the public health department, I think you're also failing us. Because you need to screen the water sources. These guys who are vending water, that they may actually the carriers. Then in one of our proposals, we wrote that you need to escalate on your food handling diseases. Currently, you're only doing, I think, typhoid, stool and overseas. But you haven't even included brucella, which is also one of the, food contaminants. I mean, one of the diseases that people can get through food and water. Now you see now cholera. So I think where we are not working as a team. Like when you complain that there's no finances. Even at university here where we work, sometimes we go on our way to educate the community as far as, hygiene is concerned. But the Department of Health, especially the devolved system from the sub-county level, they're just sleeping over the work. And I think we need to do something now. Yes, thank you.
Thank you, Dr. Kai there. Right, maybe you want to also continue. I think there was a comment from him.
I think you asked the question whether doctors are responsible for this, and I must speak because I am the chair of the Kenya Medical Association. Yes, and I must speak for that. I think sometimes when a question like that almost is looking like who do we blame, and I'll just go back, and I think I was very clear about this, that let's not come here to point fingers necessarily.
But we need to point fingers and also point the directions, isn't it?
Where
are we coming from? Where are we going?
I think what we need to clarify are the facts, and then the facts then move us in terms of direction. And the fact is that cholera is a bacterial infection which is spread by ingestion of contaminated food or water. Now, where you eat that food and water is not in the hospital. Right? Where you eat that food and water is an issue, and that's why I went back to describing the social determinants of health. That health, it's sometimes when we think health, we are going back to, we are seeing doctor, we are seeing nurse, we are seeing hospital. And in terms of cholera, those are not in fact, if all the other systems are right, these last people, the doctor, the nurse, the hospital, shouldn't even have to deal with them. Remember from what I said in terms of how the disease presents, in terms of 80% of it, it's mild disease that doesn't even get to those people. It's only the 10–20% who get severe disease who actually end up in the hospital. So it is the smaller proportion who will actually be in contact with the hospital. The greater proportion, who are the ones who are spreading it in the system, don't even reach there. It goes back to what I have just been talking about. It is the water, it is the sanitation, it is the food safety. Those are the actual critical areas. And I like to focus on facts, the ones which will make us focus on what needs to be done. Because even if we could provide IV fluids and ORS in the hospital and the antibiotic where it's needed for severe disease, that's just the tip, as Dr. Kinyari said, that's the tip of the iceberg. The bigger part is out there in the community, and that is where we should be focusing. That in terms of our public health systems, yes, there is that link between us as the health professionals and going out in terms of advocacy, but it is within the greater public health system that that structures have to be set right. And it's that collaboration again. As I said, it's not just health alone. It's not the county health by itself. It's not the public health by itself. It includes the water. It includes the housing. It includes, all the different areas. We have to come together. And each of us, I think, maybe what happens is almost we work in silos. Huh? I am Ministry of Health. I do this. Nairobi County, I do this. I am Nairobi Water and Sewerage Company, I do that. And you're forgetting they all are related, they're all interconnected. That is the bit where we all need to come in. And even as the doctors you've asked, whether it's the nurses, that's where we come into this whole system. It's almost like, would I say, like a three-legged stool, that if one leg is broken, then it's tilting. Yes. We are all part of the process. In different ways, we contribute in different ways. But of course, there is someone at the end of it. This is at the top of it in terms of control. Yes, it would start up with the Ministry of Health, whether it's a county or the national government, but drawing in all the other sectors. You cannot leave out water and sanitation when you talk about cholera. That is what it is. And as I've said again, you're going to get it where you eat or what you consume, where none of these people may be. So it goes back again to the individual. But what is this system doing? It's providing you that information so that you're careful. And we're just talking during the break. I said I went for a meeting at one of the hotels on Tuesday, and I looked at the food selections, beautiful salads. And I said, what is the message I've been preaching to people? Boil it, cook it, peel it, leave it. I said, salad? No, I can't. It's not boiled. It's not cooked. I can't peel it. Leave it. So it's that sort of messaging that we are saying. And so I'm not running away from your question of who's to blame, but to say who are the players? How do we come together? How do we move the next steps? Yeah.
Very cleverly just ran out from. Yeah. All right, we have Professor Gidi hanging on the line before we continue, Teresa, and also Dr. Suleiman. Let's start with Professor. Professor, good morning.
Hello, good morning.
Morning to you, Professor Bibi.
Yeah, can you get me well?
Yeah, we're keeping well. You have a question or a contribution?
Yeah, I'm coming from Mombasa. I have a question and just a slight contribution.
Please.
One, I was looking at the food handlers situation.
Yes.
We know that they are the first victims whenever we have an outbreak.
Yes.
You close hotels, those small restaurants.
Yes.
But to our knowledge is that we rarely have any food handler who comes up with cholera.
Mm-hmm.
We have never detected cholera among the food handlers. That's number one.
Yes.
Number two is that what kind of tests can we do on those food handlers that could indicate they are healthy to serve in the hotel industry, as far as cholera and other bacterial infections are concerned?
Yes.
Finally, I would have liked to see the role of the Kenya Medical Research Institute as far as these outbreaks are concerned.
Yes.
And my last question is this: what is the cost of these certificates? Because they're being charged, they are not being tested free. The certificates are issued at a cost. What kind of cost are we talking about?
Okay.
Thank you, ladies and gentlemen.
Right. Okay, let's hear from Professor Gidi right now, calling from Thika.
Thank you.
Thank you, Professor. Right, Doctor. Hello, good morning.
Morning.
All right. Hello, good morning.
I think there was a mix-up.
Yes, I understand. I beg your pardon for that. You can go full step ahead with your question.
Yes, okay. It's actually a comment.
Yes.
I'm one of the older generation who lived in Nairobi many years ago.
Yes.
And one of the reasons I want to make it is that in our time, there were no water bouters, no water vendors in town. Mm-hmm. So the big question is, who licenses these water sellers?
Yes.
You see, cholera is an indication of a breakdown in the provision of services.
Yes.
Full stop. So when we don't dispose of our waste properly, when we cannot turn on water and feel safe, what's happening now is predictable. So when we rush and close down kiosks along the road and wholesale, where I can do the wrong thing, I agree with Dr. Kitulu and her colleague.
Yes.
We're dealing with the tip of a problem. What Dr. Debarl and his team and similar people should answer is actually invest in water management and distribution, period. Mm-hmm. That's my contribution. Thank you.
Thank you very much. All right, we want to also hear what you have to say on social media. We can see a rush of tweets as well. And Usha, she's standing by. Usha?
So if you haven't gotten your comment through #AM Live NTV, that is how you can reach us. So starting with Facebook, we have Dorothy who says, please get a solution for our hotels. Moving on to Twitter, we have Ndenga who says, this is Kenya, common wananchi don't matter. It takes a CS to get cholera for action to be seen or to be taken. I don't know if the panel agrees with this. Does it get to that extent before we actually take it seriously?
Teresa, we should ask that question. If BD had not really or it was not the cabinet secretaries, or the people in the upper reaches of government wouldn't have highlighted this particular story.
Yeah. I think you're right. I mean, it's really obvious. We can't really hide that, because we've had cholera outbreaks on and off in different places, but the fact that they affect low-income people, basically, they're really at fault. They don't have water, they don't wash their hands. But when it affects someone at a higher level, then it becomes an issue. But I'm glad for that fact, because we've actually now been able to realize, it's a wake-up call for us to actually do something about it. And as the Public Health Society of Kenya, we are not looking at the fact that it actually affected high-level people. We are looking at an opportunity for us to come together to actually be able to solve the problem, especially looking at prevention. And like Professor alluded to, prevention is so much cheaper because we have members in our Public Health Society of Kenya who are economists and health finance, and they can actually give you a unit cost of preventing versus a unit cost of treating cholera. It's mind-boggling. And it's really, even when you go to the vaccine, as Jackie says, it's like trying to use a gun to hit a housefly. I mean, really, we have limited resources. We are looking at sustainable solutions. We really should be able to be talking to each other. And given that we have this situation, we need to not just do it at a higher level, but go all the way down and sustain the practice. Yeah.
All right.
Right. Moving on, we have Johnny who says the fact that informative discussions like the cholera outbreak do not feature on prime time makes the media part of the problem. Yeah. We also have Sidwaka who says, good panel, we Kenyans too are to blame. We are not diligent with our jobs. Inspectorate and licensing departments have failed. We have Odero who says, another great conversation, public health is essential. We have Samuel who says, at this time, cholera in Nairobi is seriously needs both private and public participation. Personal hygiene is of importance. We also have Ndenga who says, our public systems have failed and Kenyans have devised ways of trying to fill in the gap from clinics to water points. We have Richard who says, sasa nitakula lunch wapi? We have Frank who says, CS Mailu can't touch on Western Hotel. That's where impunity and favoritism has gotten us too. And finally, we have Steve who says, and we boast of being developed, yet we can't provide the basic of basics that society needs. We're still at 1963 in terms of battling diseases. So a lot of various issues, but a lot of people seem to think that we can't place the blame on specifically one group of people. Everybody has a role to play. Remember, this is a conversation that you do have to take part in because we all use water, we all drink water on a daily basis. So #AM Live NTV, that's how you can keep the conversation going, and we will be happy to sample your feedback and to get the panel to answer some of your questions. Debarl.
All right, thank you. And how potable is our water? That's the biggest question. Of course, that is the source of all this trouble that we do have. And maybe we can hear from Professor Jaoko, because they talk about the food handlers. I mean, why is it an oxymoron? I handle that particular food, yet I don't get affected. Am I a conduit of passing this particular disease? What is the science behind this?
Yeah, food handling, it's usually the problem is the carrier states. People who are infected but are not sick. Because if they are sick, they would not actually be there to handle the food. And there is a professor was mentioned there about food handling and cholera. It's actually true. Food handling cases for cholera are not as common as what you'd find, for example, in typhoid. But all the same, when you are instituting public health measures, you have to address the issues of food handlers as well. So the idea that food handlers should be left out of the equation, I'm not finding that argument a solid one. I would still do what needs to be done about ensuring that our food handlers are are healthy, to avoid any contamination of the food, even if the risk is not as high as it would be with other diseases.
Maybe Dr. Wala, you want to respond also on the water management that Dr. Suleiman had raised, or is it Professor Bibi? Yeah, the water management system in this country, right? Jacqueline says we are, just operating on our sphere of influence within our silos. We need to be integrated. Water management, is it poor? Even if we have treated water, we have also a compromised sewage system. What discernible difference does it make?
I think it's what we've kept on reiterating, a breakdown in service provision, and the fact that we as citizens do not appreciate that provision of safe drinking water is a right under the Constitution of Kenya. I live in an estate where I have to buy water, yet there's piping and there's everything. But the corruption cartels have turned it off, and so we have to get from Bowsers. We even have a politician who's supplying us for free when they're called upon. So it's even being used as a political tool to say, you know what, this person has failed, but I can do this and that. So we need to go back as citizens and demand for our rights. I think that's where we do not know the power of our voices, that we can actually go to the streets, we can go to the law, to the courts and say, this is what the Constitution has given us, this is what we are getting, let us get what we are supposed to get. Because it's their mandate. We are paying taxes, for goodness sake. We have, these things were there before. In the 80s, I hear, that people were never, I mean, you'd go to a public hospital and get the services, you'd go to, water was provided, electricity was constant. Where are we going wrong as a country? So when you look at all these things that are coming together, we need to demand for those rights. It's not a favor they're doing us.
And being also now that we've turned to be a nation of litigants, I know, why has someone not really gone to the courts to sue the government or not really, giving us our rights, when it comes to clean water as well. But as even we are now closing, this particular session, and you headline thoughts as well, you have the Health Act that now, has been ascended to by the President, I think 2 weeks ago? You should clap for yourselves. Finally. I think it has been a big debate for quite a while. We want to know what discernible difference will it bring also to the health sector right now? What is really encapsulated? I know I've not really gone through it. I went through the draft. That was way back, and I think everything went over my head. But you want to tell us what discernible difference will that do? Now we have the Health Act, but we don't really have the Disaster Management Act. It's still a bill. Is it 10 years, 15 years down the line? But they need to go in tandem. If you say cholera is a disaster and the bill is not there, how would that also affect?
Correct. I think in terms of all these acts, these bills, the most critical part is the implementation of what is in there. And I think as a country, we are excellent at research, at collecting data, and putting, reports. And of course, some things have to be enacted in law so that at least they're anchored, and there's a reference point. But I think what is more critical then is the translation of that into action. We are at a level where we sort of celebrate people doing what they should be doing. At the moment, we celebrate the CS Matiang'i. and because he's doing exactly what he should be doing. And then, in a sense, it should be a given that, after all, that's what I'm prescribed to do. So I think what is critical, we have the act, we don't have the disaster one is yet to come into place. But I think what is more critical is implementing what is there. And the implementation goes now back into, you see, the implementation will not be done by someone, nobody, anyone, anywhere. They are prescribed people. And that is where we need to get each of the teams coming in. The same things, what we have just been talking about and reiterating over and over, that we actually have to come together. You know, that fear of, they're private, they're public, they're medical services, they're public health. No, we need to come as a unit and say that when we are dealing with an issue, let's put into practice what we have set out there. And I think that is, for me, I think it is a more critical issue. We can have all these beautiful documents and things sitting there which we never get to implement. Our clarion call should be, let us do what we should do. And it's all of us.
Thank you.
You have a role too. And I think I appreciate you for getting us here to say what that role is.
We're doing this on a regular basis.
And we shall come. Invite us, we shall come. We shall come.
Let's hear from Teresa. Now we have the National Disaster Management Authority, right? And we don't have the act itself. What is, how are they really empowered by the Constitution without this particular act per se? Very briefly, as we're winding up.
I think the main thing, like Jackie has said, we basically have not been able to link the two in terms of being able to what a disaster is. I think there are
Was
things
it
that
on oversight from the health sector as well, that maybe they should have pushed these particular envelopes together?
Yeah, I think it's involvement, because ideally you should involve all stakeholders when you're putting in something that is cross-cutting like that. And of course, that means that most of the public health aspects were relegated to the back. So that means that our preparedness for communicable diseases like cholera then is not prioritized, and that then becomes an issue. So the Disaster Act is okay, but doesn't prioritize most of the public health issues. And again, as Jackie has said, we need to have accountability forums for citizens, because where do you go? For example, if you have a sewage problem, you don't have water, who do you go to? Who do you ask? We just say, oh, it's corruption. Oh, we can't do anything about it. So I think we really need to change our attitude as citizens and demand for that right, because it's actually in the Constitution, in a way that there's a response system, that a ripple effect to higher levels, and really to do something so that we don't wait for disasters or politicize the issue.
All right, thank you. Professor Jaoko, I know maybe now that's Suputingiza, then that you normally go to now, you'll be granted to do so because of what is really happening right now. But what we've not really highlighted as well is maybe you can give us, some of the high spot when it comes to symptoms, because that's very key. And we'll be remiss if we don't actually end this show knowing what these symptoms are, because maybe many Kenyans just say, oh, I had a headache, a stomach ache, and then I took Panadol and
Okay, so the main symptom in cholera is actually diarrhea, a running stomach. So there are grades of clinical presentation from a mild form to the very severe form. So usually it would start with a running stomach, and initially the diarrhea is not different from that of food poisoning, but shortly after it becomes what you call rice water diarrhea, like when you wash rice and the water that comes from the washing of the rice. So it is very light, it's watery, very, very watery, and the bouts become much, much more frequent. You can hardly sit. And that is what results into dehydration of the body. The next common sign is then vomiting, but the vomiting is usually associated with much more severe cholera. So at the beginning is just regular diarrhea, frequent going to the bathroom, and then it becomes profuse, watery diarrhea, and then you start having vomiting. And what kills you is actually not the cholera, it is the dehydration, because you lose tons of water. And so what we can advise people at home as well, if when you start having diarrhea, is just to rehydrate, to keep on drinking water, as much water. So you can boil your water and then drink the water, plenty of water. Even on your way to the hospital, you'd save a life if you continue drinking water. Even if you're vomiting, you vomit, but keep on taking water.
Thank you, thank you.
Yeah.
Dr. Elizabeth Wala, your closing remarks as well. What is the way forward, very briefly?
Yes, I think the way forward is honest conversations that need to happen and taking measures where, because all the steps that need to be taken are clearly outlined. So we should not be ashamed of calling the animal cholera, because that makes or breaks a nation.
Thank you.